Good afternoon, good evening, and welcome. My name is Preben Christensen. I'm the director in SPZ Lab. And tonight I'm a very pleased and happy person, first of all, to see so many people here. And I can tell you that there are approximately twice as many, or perhaps even more than that, listening to us right now. Most of them in Denmark, but we also have people from Norway, Iceland, Sweden and Finland. We don't know how many, but we have sent invitations out. In front of us, we have a very exciting program with 3 speakers. First, we will hear Dr. Fischer from Hamburg. After that, one of our previous patients will talk about the case for him and his wife. And finally, our nutritionist will talk about how the diet affects fertility. The second and third talk will be in Danish, but for the first part we will speak English, as Dr. Fischer also is speaking English. With regard to Dr. Fischer, he has been for many years the head of Hamburg Fertility Center. He is really one of the most experienced fertility doctors in the whole of Europe. You may know that the first IVF treatment was done in 1978. At that point of time, Dr. Fischer was a young doctor, and he decided that he wanted to work with fertility. So already the year after that, in 1979, he was starting to work in this field. He went to Nottingham, he went back to Germany, where he started to do treatments. And also, he is a co-founder of the European Fertility Society, ESRA, and he is one of the co-founders of Hamburg Fertility Center. So we have a very experienced man talking with us tonight and sharing his experience on a topic called polar body diagnosis. And just brief, polar body diagnosis, what he will come into, is a way to test the oocytes to know exactly what oocytes should we use for treatment. But now we will be transferred so we can hear from Dr. Fischer in Hamburg. Thank you.
Hello, everybody. I hope you can all hear me and see me. I'm Dr. Fischer, and as you heard already, one of the doctors, actually the medical director of the Fertility Center in Hamburg. And the topic I would like to discuss with you today is polar body genetic testing for aneuploidity. Is it helpful? We started working in this field of testing for a genetic euploidity of the oocyte already about 25 years ago. And Professor Held was the genetician at that time to fight here in Germany for a license to do this kind of testing. So in 25 years ago, we received the permission for the Ministry of Health so we could start testing genetically if a fertilized oocyte is genetically normal or not. And here you can see members of the group who are involved in this field here in my center. Now, basic problems that we are facing in ART are advanced maternal age, repeated implantation failures, and repeated pregnancy loss. And there is one thing that might be in common in all this situation, and this is the genetic information of the embryo. Now, as you can see from this presentation in Fertility and Sterility Journal, in advancing in maternal age, we are having more and more oocytes which are not genetically normal, and we are having multiple failures in this oocytes or embryos, and they, of course, have an increasing role why we are seeing these three problems that I have shown you before. So the question was, can we test the embryo to see if it is genetically normal? And it all started first about 30 years, more than 30 years ago, by testing the polar bodies. And the polar bodies are this little round things here next to the oocyte. When the oocyte, after having reduced the number of the chromosomes, and I will explain you immediately why and how, is getting rid of the unnecessary chromosomes in this little satellites that you can see here. The other way was to take one of the blastomeres from a day 3 embryo, which is not done anymore. And what is quite common in many countries is to use the trophectoderm to take cells to examine, or the amniotic fluid. Nowadays, it's also started with checking for free DNA in culture media to see if the embryo is genetically normal. Now, we know for testing that most of the failures why an embryo is genetically not normal is due to the oocyte, while reducing the number of the chromosomes from 46 chromosomes to 23 chromosomes. This is called the first meiosis. And the second meiosis is when the 23 chromosomes are reducing half of the chromosome getting out and the half of the chromosome staying in. So about 85% of the failures do come from the oocyte. The sperm is not involved very much in these problems. Roughly about 5 to 10% of the not normal embryos are due to the sperm, and about 10% are due to failures will happen after the fertilization, which is called postzygotic or postmitotic failures. Now, the reason why we have in advanced age a problem is because the oocytes are aging. They are not produced because they are in the body since the birth. And you can see how the spindle, which is involved in reducing the number of the chromosomes in the egg in a young female in an advanced maternal age. The second problem that happens with aging is this part here at the end of the chromosomes, which is called the telomeres. They are getting shorter and shorter. And because of this, the bridges between the two sister chromatids disappear. So the chromosomes now in the chromosome itself are not attached very well together. And this is causing a problem. So usually a normal meiosis, you will see here now 46 chromosomes, 2 times 23 chromosomes. And we have a reduction to 23 chromosomes, and 23 chromosomes go outside. And it is called meiosis, and that happens in the oocyte during the ovulation time. After that, during the fertilization time, we have the second meiosis. So the oocyte will reduce now to 23 sister chromatid, and the other sister chromatid will go out. So the oocyte remains with 23 half chromosomes, because the sperm is also coming with 23 half chromosomes. Now, if the binding between the chromosomes are not very good, you will see a separation of the chromosome already before it should happen. And then mistakes might happen by reducing the number of the chromosomes or reducing the chromatids. So we shall end up with either too many chromosomes in the oocytes or not enough chromosomes in the oocyte. And this is a problem because if an oocyte where we have not enough chromosomes even one chromosome is failing, this kind of oocyte, which will develop to an embryo, will never implant. If there is one additional chromosome there, we call it a trisomic embryo. This trisomic embryo can implant if they become a blastocyst, but this embryo will not continue to a delivery because it will end up mostly with a miscarriage. Only chromosome 21, chromosome 13, and chromosome 18, if you have a trisomy, can continue to be delivered, but only chromosome 21 is possible to continue living as a Down syndrome. Deliveries of chromosome 13 and chromosome 18 trisomic will die immediately after delivery. Now, it is also important to know that we don't have what we call mosaic observation when we check the polar body, different when we check the embryo itself, and we shall come back to that a little bit later. It has also been shown that the finding normal genetically fertilized oocyte is independent from the number of the oocyte that we have during, for example, a stimulation. So a softer stimulation or more stronger stimulation will not change the rate of the normality of the fertilized oocyte. On the other side, the more oocyte you will have, the higher the probability that we shall find at least one normal genetically euploid fertilized oocyte. And this is also not dependent from the stimulation gonadotropins that we are using during an ART treatment, and not by the dose of we are using. The only effect is by the age of the female. This is the only dependency that we see. Now, mostly in the world, euploidy testing is done on blastocyst, and we still have some question marks and problems, because if we look what is the pregnancy rate if we transfer a so-called euploid blastocyst, it is not 100%. The best results we are getting in good center is around 60 to 65% only. And there is no 0% pregnancy loss. So there must be, of course, some problems that we have to look into that. Why a euploid blastocyst will not implant, and what we still have miscarriages. Other problem is that not every patient will have a blastocyst, because the blastocyst rate, especially if we go in advanced age, is not 100%. And some patient will not reach a blastocyst, so we cannot test if the fertilized egg was normal or not normal. And also the quality of the blastocyst will have an impact if this blastocyst will survive the biopsy and continue to a live birth. So in this study in the US, they looked at similar grades of blastocysts and the amount of cells taken from the trophectoderm for examination. So if the blastocyst was very high quality, so A quality, even if a lot of cells have been taken, the probability of implantation was very good. But if the rate of the blastocyst was lower, like B or C, you see the more cells that have been taken had an effect of the implantation and reduced the implantation and the probability to a live birth, even though the blastocyst was genetically normal. Other problems that we have are so-called mosaic or segmental aneuploidity result. So what is a mosaic? The mosaic are different results from the same biopsy. Now, after fertilization, some of the cells might have new mistakes, so-called post-mitotic mistakes. So the question is where these cells are going to. Do they repair the self and the embryo stays normal and also the cells around it will be all normal? Or do we have a mixture of cells here, or we have a mixture of cells here, or maybe we just have the mixture of cells here, or all the cells here are not normal, but inside it is normal. Now, the biopsy we are taking in somewhere here. So if we shall take the biopsy here, we shall have a different result than if we have the biopsy here, or if we take the biopsy here, and it will not confirm what the inner cell mass of this is the embryo itself. So we cannot biopsy the embryo itself, of course. So we shall get results which have a mixture of normal and abnormal cells. And now is the question how accurate it will predict us what's inside the embryo itself. So many studies have been looked at that and looked at the percentage that you will get. And is still a big argument. What will be the percentage of the cells that you test as a mosaic result? And up to now, it is somewhere between 20 and 50%, depends on the laboratory one is working with, that will say it is a normal embryo or it is an abnormal embryo. But even if you have a completely normal result here, the embryo still can be abnormal, or you can have a totally abnormal result here, and the embryo can be normal. So when we transfer this kind of mosaic results, we see that the miscarriage rate is increasing, of course, but we still can have, of course, some of the embryos going to delivery. And if they go to delivery, they will have normal outcome of the embryo, of the fetus. Now, many instructions and constriction and instructions and guidelines have been used because of that. And it's always a very difficult discussion with the patients to explain to them, shall we transfer this embryo or shall we not transfer this embryo? Because we shall never 100% be able to say if the inner cell mass, the embryo itself, is genetically normal. So we have very different opinions about that, and it's still an ongoing, never-ending discussion in the community of the reproductive treating doctors. This study in the Netherlands tried to find out what is the concordance between the trophectoderm and the inner cell mass, and they did find that in generally there is a 15% difference between the result of the trophectoderm and the result of the inner cell mass after they examined and took apart really the embryo to do that testing. So even if you get a result of a 100% euploid embryo, the probability that the embryo is really euploid is only 85%. And because of that, we don't have a 100% pregnancy rate, and we don't have a 0% miscarriage rate. So when we do the polar body diagnostic, we don't have a problem with this result of mosaics, because in the polar body there is no mosaic. There is either black or white, either normal or not normal. And every mistake that we shall see in the oocyte and the polar body will be after that presented in every cell of the embryo and the blastocyst. So the inner cell mass and the trophectoderm will have all the abnormalities that we see in the polar body. These are called meiotic failures, and meiotic failures from the oocyte and from the sperm will be presented in all the cells always in the blastocyst and the embryo. Another advantage of using polar body is that we can do a fresh embryo transfer, because we are taking the sample on the first day after fertilization, and after 24 hours we have already the result, so we can make a decision to do a fresh embryo transfer. If you do a blastocyst biopsy, it is not possible to transfer in the same cycle, so you have first of all to freeze the embryo, wait for the result, and the next month you can do in the next cycle a so-called frozen embryo transfer with a so-called euploid blastocyst. So it will take more time. Now, these early studies many years ago have already shown by testing the polar body and testing the blastocyst that all the mistakes that have been seen in the polar body appeared in all the cells of the blastocyst. And Dagan Wells from the Oxford Clinic, he also tested the three problems that we have discussed before: advanced maternal age, recurrent implantation failure, and recurrent pregnancy loss. And he did found it useful to use the polar body testing to identify abnormal embryos in these three groups of patients. Now, we accumulated some data. This is some early data from our center, using now 23 chromosome testing and almost 5,000 oocytes. So you can see that up to the age of 35, about 50% of the oocytes will be genetically normal and 50% probably genetically normal. After that, we can see a continuous decline. So if you are, let's say, at 38, only about 25% of your oocytes will be normal, and you will be about 40, 41, only about 10% of the fertilized oocyte will be normal. And this is, of course, making the problems in advanced maternal age to achieve an ongoing pregnancy and a live birth. When we look at trophectoderm tested embryos, we see more or less the same situation. So up to the age of 35, around 50 to 60% of the embryos are normal. And after that, you see a continuous decline in the normality of the blastocysts. And this is, again, independent of the number of the blastocysts you'd have, only dependent by the age of the patient. We also tested to see if patient decided to have, in advanced maternal age, a biopsy of the polar body, or they decided not to have one, and to see at which age group it was helpful. And we can see that up to the age of 37, it was not really very much difference if you transferred examined or not examined embryos. These are within the first 2 cycles, because the probability was around 50%. So you might have been lucky to have the right embryo, especially if you transferred 2 embryos at that time. But over the age of 38, you see the big difference, which is going and becoming greater even over the age of 40, considering now ongoing pregnancies and live birth rate, if you tested or you did not test for the genetic normality of the fertilized oocyte. Now, why it is helpful? Of course, we cannot change the embryo by testing. It will not become a better embryo. But we can shorten the time to reach an ongoing pregnancy or a live birth by transferring a genetically normal embryo. And if we have a genetically normal embryo, you see that there is no difference now by the age of having an implantation or a live birth. So this is data from our center using polar body genetic testing. And this is data from a center in Italy, in Rome, testing blastocysts. And you see the exactly same picture. If you don't test, you have a very low probability to reach a pregnancy or a live birth. If you test, it's independent of the age, exactly like with the polar body, to achieve an ongoing pregnancy and a live birth rate. So this helps to reduce time and not to be affected by not implanting embryos or by having miscarriages repeatedly, especially in an advanced maternal age group. Now, last year, we published this paper. We compared our results from our center with a center in Brazil. Now, the reason we were comparing these results is because the center in Brazil is using exactly the same stimulation protocol that we are using. They found our protocol very interesting and implemented it in the center. So we are treating exactly the same way the ovaries for ART. And that's why it's interesting to test the results between the two centers. And because they were predominantly doing blastocyst trophectoderm biopsies, and we predominantly were doing polar body testing, it was interesting to see if we are reaching the same result by different methods of testing the embryo. So this were the group, about more than 800 patients in each center that were comparable. And we compared the outcome and the result of these two groups of patients. Now, just to see if we are dealing with the same system, we compared now frozen embryo transfers, because in the blastocyst transfer, you have to use frozen embryo transfer without testing genetically. So you see, even if we transfer 1 or 2 blastocysts, we don't have a difference in the pregnancy rate, but we also don't have differences between our center and the center in Brazil, not considering clinical pregnancy rate and not considering live birth rate. So in every age group, we have more or less the same result of pregnancy and live birth rate. Now, we looked what was the result if tested patients have been transferred. And again, you see the same picture. If we transfer one embryo, for example, in the young patient, in the more advanced maternal age, in very advanced maternal age, there is no difference between the centers concerning the pregnancy rate and no difference concerning the live birth rate, which means that with just testing the polar body for euploidity of the embryo, we can reach exactly the same result as the blastocyst trophectoderm biopsy for the euploidity. And the reason is, of course, the same, because both of us, after having a blastocyst, we don't know 100% if this blastocyst is genetically normal. As I told you, the trophectoderm biopsy, only 85% prediction possibility, even if they have a euploid result. And when we check the polar body, we don't have the information of the sperm, and we don't have the information that happens after the fertilization. And that sums together of about 15%. So when we have a blastocyst after a euploid testing of polar body, we miss about 15% information. So the probability, again, is only 85% that this blastocyst is at the end really genetically normal. So for different reasons, we have the same problem. And that's why it is not possible at the moment with any test that exists to predict the 100% euploidity of the blastocyst. But we have, of course, the possibility to transfer in the same cycle. And you can see that if we transfer in the fresh cycle, or if we transfer in frozen embryo transfer, we achieve exactly the same clinical pregnancy and exactly the same live birth rate. So it is an advantage to do it in the same cycle. And we also don't have this question mark of the mosaics, and don't have the problem that we might have discarded a euploid normal embryo only because the trophectoderm testing showed a high mosaic rate, or maybe an aneuploidity, and the embryo was really euploid. So this hazard is not happening with the polar body. Some data now from advanced maternal age. And now here you can see about 1,000 patients that we checked. And you can see that in the older patient, only about half of them will receive an embryo transfer, because 50% of this patient had genetically abnormal embryos. So there was no reason to transfer them. So we actually saved the time for this patient so they can continue and have a new stimulation and hope maybe in the next stimulation to have a better embryo. You can see that this percentage is of course different in the younger patient and also in the very young patient. When we transfer the embryos, you see that the pregnancy rates are very similar in the different big age groups. The same for the live birth rate and the miscarriage rate. So here we look now at percentage of pregnancies in fresh embryo transfer by the age. And we have now the different age group. And this is now advanced maternal age. And as you can see, these are patients who tested, and these are patients who did not want to test. And you can see that in the young patient, it makes no difference. In an advanced maternal age patient, it makes a big difference concerning pregnancy rate. These were patients with repeated implantation failure. So for us, repeated implantation failure, it was if they had 4 or more no pregnancy after 4 embryo transfers of good quality blastocyst. Some of these patients have after 12 embryo transfers. So here you can see that in every age group, they benefit concerning to those who did not test for reaching a pregnancy. And this was now the repeated pregnancy loss. So here you can see no difference concerning the pregnancies, because the problem of this patient is not to get pregnant. They become pregnant, but they lose the pregnancies. So we cannot see a difference in becoming pregnant in this patient. But when we look at the spontaneous pregnancy loss, you can see in this patient a big difference. So it's in every age group, they benefit from doing genetic testing for euploidity concerning to those who did not test. So this was the pregnancy loss, and this was the pregnancy loss of those who do test. Again, if we look at pregnancy loss in the age group, again, in the advanced maternal group, the more advanced age benefited more than the younger ones. And in the recurrent implantation failure, all of them benefit compared to those who did not test. When we look at live birth rate, again, in the repeated pregnancy loss patient, you see all of them benefit to those. So this is the live birth rate to those who did not test, and this is the high live birth is significantly better. The recurrent implantation failure, again, all benefited in all age groups comparing to those who did not test. And in the advanced maternal age, again, only the patients over 38 really benefit from testing for genetic euploidity. The other possibility that we can use polar body is if we have a translocation a translocation means that two pieces of chromosome, neighbor chromosomes, broke and changed location. So we have a piece of this chromosome here and a piece of this chromosome here. And in this situation, that depends how the chromosome, because only half of the chromatids will go on. About in 50% of this patient, they will have either too many or too little chromosome pieces going on to the embryo, and 25% will just give the translocation to the next generation, and 25% will give the normal part. So this part and this part will be 25%, this part and this part will be 25%, this and this, or sorry, this and this and this and that will be about 50% altogether. So these are the patients who are either not getting pregnant because of the translocation or having one miscarriage after the other. Now, the probability in this situation to find if it is a female translocation is possible to check on the polar body. But because even in the younger patients, we have only 50% generally euploidity rate, and now having about 50% not euploid just because of the translocation between these two chromosomes. So only in about 20% generally we might be able to find at least one embryo which is genetically euploid, even in the young patient, and it might be even lower in advanced maternal age patient. So we shall need a much higher number of fertilized oocytes in this case in order to achieve a pregnancy. And here you can indeed see in the different age group, the percentage of transferable embryos was generally about 19%. It was a little bit lower in the upper age and around 20% in the young patient. But once you transfer the embryos, they have a normal pregnancy and a normal live birth rate. So it is possible a translocation, female translocation, to detect by the polar body genetic testing. Male translocation, of course, not possible. In that case, PGTS needs to be done in order to find the translocation by a trophectoderm biopsy, of course. Some additional information. What happens if we remove the polar bodies? Well, in about 4%, the oocyte might suffer and degenerate. It is usually the case when there are still some bridges between the polar body and the cytoplasma, the cell of the oocyte. Nowadays, our biologists and embryologists are very good trained. So with special microscope, they can see if there are still bridges, so they will avoid removing the polar body in that case. And from the genetic part, sometimes the polar body is fragmented very strongly, and there will be no possibility in the genetic testing to amplify and to read a normal result. And that happens in about 7%. And this is what usually in good laboratories, also with the trophectoderm biopsy, is usually seen. So to conclude, I've shown you that the major application of polar body genetic testing is good for detect maternal-derived chromosomal abnormalities and translocation. I have shown you that it is of advantage using it in advanced maternal age, in recurrent implantation failure and recurrent pregnancy loss. We need to check, of course, both polar bodies. And when euploid embryos are transferred, we have normalization across the board of female age, concerning implantation rate and live birth rate. And I've shown you that polar body genetic testing is as good as alternative to a blastocyst euploidy testing. And just a picture of the inside of Hamburg. Some of you might have been here already. This is the Fertility Center of Hamburg, and it's somewhere here in downtown Hamburg. So thank you very much for listening. And I'm very happy now, if you have questions, to answer your questions.
Thank you to Dr. Fischer for a very interesting presentation. I hope that we have a question or two from the audience. I will ask a question then. Now, Dr. Fischer, the polar body biopsy is much more precise than the blastocyst biopsy, which we are not doing very often here in Denmark. Actually, there's only one clinic in Denmark doing the biopsy of the blastocyst. And the blastocyst biopsy also has a risk of being detrimental. In Denmark, we have, and this is the reason actually I wanted you to talk about this tonight. In Denmark, we have a number of questions, a number of women who are more than 38 years of age, where the fertility clinics are pushing them towards having egg donation. And what I would think is that if I was a woman here in Copenhagen, wouldn't it be a good idea? First of all, if you are wanting to achieve fertility naturally, then you have to wait for a long time, because as I heard you, only 10 or 15% of these oocytes are actually competent. Is this correct?
This is correct.
Yeah. So if I tried naturally to achieve pregnancy when I'm 40 years of age, then it would take me 1 year. You can do that in one cycle where you stimulate, so you have 10 or perhaps 15 embryos to select from.
Well, it depends, of course, with the ovarian reserve, because this is the second problem that happens in advanced maternal age, that in some female, the ovarian reserve is lower. So sometimes we need repeated cycles just to have enough number of oocytes, depending, of course, of the reserve. But the problem is that time is very crucial at this age. So the longer you wait after 40, the probability, if you are 41, to find a normal fertilized oocyte, is only 50% from what was the year before. And then it continues going 50% lower every year. And that's why time is very crucial in this age group.
So when the woman is 38, she should have tested her AMH, so she knows exactly how big is the ovarian reserve. Now, from Copenhagen to Hamburg is a very short journey. You can take the train, and you said here in your presentation that if you're doing a fresh transfer, you can actually have a prolonged weekend in Hamburg and having oocytes taken out, tested, and actually going home and be treated. And of course, one important question is, how much does it cost? Is it more expensive to do polar body biopsy than it is to do the blastocyst biopsy?
Well, it might be more expensive because you have more embryos to test, of course. Blastocysts, you don't have so many, so you have more to test. We also do, in some cases, when we have more oocytes that fertilize, to try to make it a little bit cheaper, we are taking out the polar bodies, but not examining them. We are just preparing them for examination. And then we wait to see which of these fertilized oocyte becomes a blastocyst. And then we freeze the blastocyst, and only then we check for these embryos, the polar bodies that we already have taken out. So that can reduce the cost of the genetic testing, because this is the most expensive part in this situation. But it prolongs, of course, because we shall need a second cycle to do the embryo transfer. But this is also manageable. So this is, of course, important to a patient to have 8, 9, or 10, or even more fertilized oocytes, because then it will become very expensive.
And how much would it cost to test one oocyte for all three chromosomes in the first and second polar body?
I can tell you immediately. I have to look at the tables because we checking by the ML. So the most expensive one is the first oocyte, because you have to make all the preparation. Each oocyte that is coming after that is getting cheaper and cheaper and cheaper. So to do the biopsy cost for one oocyte costed €350 just today to do the biopsy, and the testing will cost about €600 genetic testing. But then for biopsy on two oocytes cost already only €460, so it's getting cheaper, and the two together is already 460, and testing genetically will cost €811. And this is why, because the preparation around it is making it very expensive. And the more you have on the platform, because the platforms are very expensive, what we get from the genetic companies that produce it, the more you have on the platform, the cheaper the situation will become. And that's why we are discussing always with the couples how much they want to invest and how many should be examined. They can also decide that they only want to examine, let's say, 4. And if they have, let's say, 8, then we just freeze the embryos and wait for a frozen embryo transfer cycle. So there are all kinds of possibilities to discuss about it, but that might, of course, prolong the time until we know when we find an embryo. Because if we have somebody who is 41 years old, the probability is only about 10%. So if you if you look at 4 oocytes, there are 10% in 4 oocytes. If you are lucky, it's there, but if you are unlucky, it's not there. And then you're just losing time because you did not check, let's say, only all the 8 that you have, and you might have a better chance to find.
Yeah. Thanks a lot, Dr. Fischer. It doesn't seem we have more questions here, so thank you very much for this presentation. So, sorry.
So I've heard that for males, right, you can do stuff to increase your sperm quality. So I was just wondering if there's something you can do as a woman to increase the genetic quality of your oocytes, or if whatever I do is only affecting my daughter's oocytes.
Well, I'm sorry to disappoint you, but there is nothing you can do to affect the genetic euploidity of your oocyte, because this is something that's programmed by the age, and you cannot change this programming. We cannot make ourselves younger and not the oocyte younger. So doesn't matter what you do, this will just happen by chance. So the probability of luck is getting bigger and bigger and bigger the older you become. And that's why it's not possible to have any effect on that by anything you want to do. So all these add-ons that are in the internet, they will not do any good and any help. So we don't recommend to do all that list.
Thank you. Yes, yeah.
Hi, I heard that hormone stimulation could cause like a worse egg quality because you're actually forcing more eggs to mature. So what is your take on it, especially taking pregnancy loss into consideration?
Well, that is again incorrect. The stimulation doesn't affect the genetic situation of the oocyte and not the genetic situation of the embryo. That's why I showed you at the beginning the slide where you see that the rate of euploidity is the same if you do a strong stimulation or you do a very mild stimulation. On the other hand, if you have more oocytes and more embryos, the probability to find a normal one is bigger, and you shorten again your time. So by stimulating, you only stimulate the follicles that arrive from the reserve and are there at the time of menstruation. And you cannot affect what will come from the reserve and arrive. So you are just stimulating those who are there. And you have no effect by the stimulation of how the genetic situation of the fertilized oocyte will be.
So, one more question.
What about progesterone level? I heard that that could also affect the implantation and pregnancy loss, especially in mature age. You might have less hormone production.
Yes, this is correct. The progesterone plays a very important role in the implantation, in opening the window of the implantation, and also a lot of all the immune system during the implantation is connected to the progesterone. So progesterone is very important, and it's important to have a good level of progesterone. But on the other hand, you need a normal embryo, genetically normal embryo to implant. So if you don't have a genetically normal embryo to implant, there will be no pregnancy. And if the genetic situation of the embryo is abnormal, you can have a pregnancy, but also a miscarriage, even if you have a good progesterone way. So both of them needs to be there correctly.
Good.
Okay, I just have one question from the chat. So to you, Robert, if you have 4 pregnancy losses already, PGT-A tested, would it make sense to try this testing also?
Sorry, I did not understand the beginning of the question.
You have had 4 miscarriages. Would it be advisable to have PGT-A?
Yes. You even in the young patients, we suggest to do PGT-A for if they had at least 4 pregnancy losses. In advanced maternal age, even if they had 1 pregnancy loss, we suggest to look. In the younger patients, sometimes there are some other reasons for the pregnancy loss. That's why we see a benefit only if they had 4 pregnancy losses.
Okay, yeah, sorry. So the asking person here says that it is PGT-A tested already. So
so after PGT-A, they had pregnancy loss. Yes, was that the question, or?
Yes, that's right.
Oh yeah, I see. So one situation is that the question if the embryo was normal or abnormal, and that's why it's important. So we do it generally that if there is a pregnancy loss, we try to find out what was the genetic of the embryo of the fetus that was lost, and this is possible to test for it, and so to see if the embryo was really normal. Now, there are, of course, some other reasons why there is a pregnancy loss, even if a normal embryo implanted. One situation is that we can have a pregnancy loss not because of the number of the chromosomes, which is tested by the euploidity, by the PGTA, but because of what mutations of diseases that might have happened in this embryo. So they have a normal number, but they have some new mutation that doesn't allow the embryo to continue. And then it's very difficult to find that out. Some of them might have a thrombophilia, so they lose pregnancies because there is a problem of thrombophilia, so it needs to be checked for that. And some might lose because the microbiota of the uterus is not correct, so they might have a chronic endometritis, a chronic inflammation, or they might not have sufficient lactobacilli in the uterus, and that's why there is a loss. And there is also a subgroup that we also are checking for that, but the implantation window was not correct. So the embryo implanted not in the middle of the window, but on the side of the window, and the implantation was not complete. And then there is also a problem of DNA fragmentation that Preben can tell you a little bit more about that, that a patient with very high fragmentation in the sperm might produce embryos that will implant. They will be genetically normal by the chromosome number, but the quality of the embryo is poor, and this ends sometimes with biochemical pregnancies. So these are things that needs to be examined if repeated pregnancy losses occur.
This was a fantastic comment to stop with, Dr. Fischer, because the next speaker tonight is actually Claudio, who comes from a couple where they had problems with pregnancy loss. So thank you, Dr. Fischer, for participating here and answering the questions.
Thank you very much. All the best here from Hamburg to Copenhagen.
Thank you.
Bye-bye.